guests, welcome to today's forum. We're so pleased to have you here with us, and we're honored to have such a wonderful group of speakers and participants to join us. Please be reminded that all speaker bios can be accessed by scanning the QR code provided. We'll also be using Slido for the Q&A session. Please scan the QR code on the screen as well as the back of the postcard you received at the registration table. To begin our program, it is my pleasure to introduce our moderators for today, Dr. Simone Keizer Beache, the Chief Medical Officer of the Ministry of Health, St. Vincent and the Grenadines.
Minister of Health and Welfare in Taiwan, Dr. Clair Prince. Minister of Health, Wellness and Environment, the Honorable Clair Prince of St. Vincent and the Grenadines. Vice Minister, Dr. José Ortellado, Vice Minister of Public Health and Social Welfare of Paraguay. Good afternoon, good evening. Other invited guests, panelists, welcome. I'm Simone Keizer Beache, Chief Medical Officer of the multi-island, small island developing state of St. Vincent and the Grenadines in the Eastern Caribbean. And I'm indeed honored to be your moderator for this evening's forum, entitled Empowering True Inclusive Healthcare, Leveraging Smart Technologies for Accessibility. With our presenters from the Japan International Cooperation Agency, the Ministry of Public Health and Social Welfare Paraguay, Terre des Noms, Land of Men or Land of People, the Ministry of Health of Taiwan, and our host, the Taiwan ICDF, we should be able to explore this topic. Through segments, we will be focused on the key components of smart technology, and those are integration, connectivity, automation, adaptability, remote accessibility, and cognitive awareness. We will explore a range of experiences and plans for the implementation of smart technologies. Armed with this knowledge and supported by willing partners, it is our intention that participants will be empowered to take full advantage of digital health and new technologies to improve access to health services, thus advancing our journey to truly inclusive healthcare. And without any further ado, I will need to welcome the Minister of Health and Welfare of Taiwan, Dr. Tai Yong-shu.
Dr. Simone Keizer Beache, Vice Minister José Ortellado, and the Deputy Minister of Ministry of Health and Welfare, Professor Li Zhende, and the Deputy Secretary General Li, Deputy Secretary General St, distinguished guests, and ladies and gentlemen, good evening. On behalf of the Ministry of Health and Welfare, it's my great pleasure to welcome you to today's forum. Taiwan is honored to host this important gathering of expert leaders and practitioners who share a common commitment to advancing inclusive health care and harnessing smart technology to improve accessibility. Since 2018, the Taiwan International Cooperation and the Development Fund, Taiwan ICDF, has come in this forum annually in Geneva, reflecting our enduring commitment to promoting dialogue and collaboration in global health. This year's forum highlights Taiwan's achievements in advancing smart health care, which align with the World Health Organization's smart guidelines. It also provides a valuable platform for sharing insights on how digital health solutions can address emerging public health challenges in line with global efforts to achieve universal health coverage, UHC, and health equity in the digital era. We strongly advocate for the standardization and the adoption of digital health system, and we remain dedicated to contributing to the global vision of UHC. Taiwan ICDF play a key role in integrating Taiwan's technological strength into a range of public health and medical projects, with a particular focus on smart medicine, smart healthcare. One notable example is the Paraguay Health Information Management Efficiency Improvement Project. Through this initiative, Taiwan ICDF successfully implemented a health information system in over 230 medical facilities, covering approximately 70% of Paraguay's population. With strong support from the Paraguay government, the project continued to expand with the goal of reaching all public health care facility nationwide. Over the years, Taiwan ICDF has collaborated with public and private institutions, both domestically and internationally, as well as with civil society, to advance Taiwan's foreign aid efforts. In the past years alone, Taiwan ICDF partnered with 10 Taiwanese medical institutions to implement 10 public health and medical projects, alongside to training programs for healthcare personnel in partner countries. These initiatives address critical public health issues, including strengthening health information systems, maternal and infant health, chronic disease prevention, and emergency response preparedness. Through such collaboration, Taiwan strives to provide comprehensive medical support to our partner countries. Once again, I extend my warmest welcome to everyone attending the forum. I wish you all a productive and engaging discussion and continued good health and success. Thank you.
Thank you very much, Minister. And now we'll invite the Vice Minister from Paraguay, Dr. José, to give our keynote address. Thank you.
Buenas noches. Sorry, my language is Spanish. The presentation is in English. Señor Ministro de Salud de Taiwán, Dr. Tai Wan-Chu, queridos oyentes, ministros, representantes de empresas y países en adelante. Yo soy el viceministro de Salud de Paraguay y para mí es un honor participar en este importante foro organizado por la República China de Taiwán. Quisiera en primer lugar expresar nuestro más sincero agradecimiento al gobierno y al pueblo de Taiwán por su hospitalidad, su visión innovadora y su constante compromiso con el fortalecimiento de la cooperación internacional en el ámbito de la salud, que ya desde años atrás, con el CICDF, estamos implementando en Paraguay. Hoy deseo compartir con ustedes la experiencia de Paraguay en su camino hacia la transformación digital del sistema de salud. Esta transformación digital es una política de gobierno, de este gobierno, que empezó en el año 2020-23, en la cual apostamos a la digitalización y la transformación digital del Ministerio de Salud Pública y todos sus servicios hospitalarios o de servicios de salud. Y en este proceso ha sido impulsado con fuerza por la necesidad de mejorar la equidad, la eficiencia y accesibilidad de los servicios sanitarios en nuestro país. Y es una experiencia propia que cuando las decisiones eran mucho más fáciles. Entonces esa idea lo llevamos a Paraguay a través de este proyecto. Y en este proyecto entonces podemos empezar que la transformación de estas nuevas tecnologías y como política pública lo estamos implementando en Paraguay en forma desde este gobierno con mayor énfasis. Hablando un poco para localizarlo a Paraguay, ¿dónde queda Paraguay? Si alguien de este auditorio ¿alguien conoce Paraguay? No. Entonces, es un país que está localizado en el centro de América, con países vecinos como Brasil, Argentina y Bolivia. Esos son tres países que están aún como vecinos de Paraguay. Además, el área de Paraguay tiene 406.000 kilómetros cuadrados y una población de 6.200.000 personas. El lenguaje que hablamos en Paraguay principalmente es el español y el guaraní, que es un idioma autóctono de Paraguay. Más bien tenemos una población indígena de aproximadamente 7% de la población es indígena y habla lenguas guaraní. La estructura de la edad, fíjense, tenemos hasta los menores de 15 años 25% de la población, una población muy joven, una pirámide poblacional joven relativamente. De 15 a 64 años 66% y más de 65 años un 8% que para el 2030 va a alcanzar 13%. En ese punto es importante también decir que la expectativa de vida de una mujer es de actualmente 77 años. Y la expectativa de vida de un hombre es de 74 a 75 años. Bastante muy corto esos años. Además tenemos lo que se llama el río Paraguay, que divide al Paraguay en dos regiones, la oriental y la occidental. La oriental es una región del Chaco paraguayo, que es una región árida, polvo, y de muy difícil acceso, pero estamos teniendo nuevos caminos y donde se realizan los famosos rallies, y el Mundial de Rally actualmente va para Paraguay. El río Paraguay es un río navegable, por la cual también Paraguay, en la época de pandemia, también hemos recibido equipamiento a través del río, a través de barcos, y no cuando se cerraron los aeropuertos. Entonces ese es el momento que también nos sirvió nuestro río para ese tema. En cuanto a la división del sistema de la población de atención de la salud a nivel paraguayo, del Sistema Nacional de Salud, que podemos estar dividido prácticamente en tres sistemas. Es un sistema de salud pública, la salud pública que está manejado por el Ministerio de Salud, abarca alrededor del 70-75% de la población. Pero este año, actualmente, prácticamente abarca aún más, porque el presupuesto, o sea, la ley, la Constitución paraguaya dice que tiene que ser atendido la población dentro de este país en forma del 100% y en forma gratuita. De ahí que si el sistema privado no puede, o sea, que la persona no puede pagar un sistema privado, va al sistema salud pública. Y hay un sistema que le llamamos el IPS, que es el de seguro de previsión social, el hospital o el seguro social, y es alrededor del 20%. Pero si el IPS no puede dar respuesta a la población, de vuelta cae al servicio de salud pública, y salud pública debe proveer en todos sentidos servicios, diagnóstico, medicamento, tratamiento y hasta trasplantes de los pacientes. Entonces, pero el IPS tiene un hospital de 1.100 camas. Es un hospital central, también está descentralizado, tiene en distintas regiones. El Paraguay tiene 18 regiones sanitarias, y en esas 18 regiones sanitarias hay un hospital de la Seguridad Social. Y del Ministerio de Salud tienen lo que está distribuido en un hospital regional, es para la región, después un hospital distrital, que es un hospital de una categoría menor que la regional, y después están las unidades de salud de familia y las unidades de salud de familia ampliada. Eso significa que estos niveles de atención y niveles de complejidad terminan en hospitales especializados en la capital. En la capital tenemos 10 hospitales especializados, de pulmón, del corazón, maternidad, de niños, de trasplante, de diálisis. Entonces van pacientes a esos hospitales especializados. Entonces, desde allí es importante el privado. El privado, hay muchos sanatorios privados de alta complejidad. Estos sanatorios privados trabajan en forma integrada con el Ministerio de Salud Pública, en gran parte. Y actualmente nuestra política es hacer lo que se llama alianza público-privada, en la que la respuesta de diagnósticos son hechos por empresas privadas, son construidos por empresas privadas, los equipamientos son proveídos por la empresa privada, y eso inmediatamente el Ministerio de Salud Pública paga servicio. Y en ese punto quiero tomarme y decir lo siguiente, algo muy particular. El ingeniero Tori ha hecho un trabajo excelente para que la información del privado se conecte al sistema GIS, que lo estamos haciendo nosotros ahora, implementando en todos los servicios del Ministerio de Salud. Entonces, informaciones de enfermedades emergentes como dengue o arbovirosis, todas esas informaciones son captadas a través de un web GIS. El GIS es lo que es el Sistema de Información Hospitalaria, y ese web fees lo estamos cargando también del privado para tener la vigilancia de algunas enfermedades, en este caso el dengue. También lo tenemos para lo que se llama un registro nacional de síndrome coronario agudo, que es los infartos agudos de miocardio. Paraguay tiene uno de los registros nacional, a nivel nacional, de síndrome coronario agudo. Entonces, ese punto de intersección de información es muy importante. Y hemos visto que el ingeniero lo puede decir que hace 10 años atrás aproximadamente teníamos 1 o 2 servicios de salud conectados al sistema de información. Actualmente de 1.600 aproximadamente de servicios de salud tenemos 950 servicios conectados actualmente. Falta poco, pero con esa información tenemos muy buenos datos a tiempo real inmediatamente. Siempre existen problemas porque el sistema de información, la tecnología o todo eso siempre depende del ser humano para que sea interactivo y que trabaje y tengamos esos datos. Entonces ahí a veces es un tema, pero como políticas públicas y políticas de salud, nosotros lo estamos llevando bastante bien con todos los hospitales. En esta mejora de la eficiencia es importante entender, por ejemplo, cómo los tiempos disminuyen en la atención y tratar de reducir las colas, las largas filas en los hospitales. Por ejemplo, en admisión significa cuando el paciente llega al hospital y quiere consultar, se han disminuido los tiempos, principalmente en una ciudad en la que una región está 100% digital, que es la región de Guairá. La región Guairá, justo donde yo he nacido, esa región está 100% con sistema de información. Y se han visto de 60 minutos bajó a menos de 10 minutos en la admisión del control. Eso regula y organiza la atención, gran parte. La preconsulta significa que la enfermería es donde se debe controlar la presión, la temperatura, controlar la frecuencia, bajó también rotundamente los tiempos del servicio de atención. En la consulta ha bajado también en un porcentaje de 60 minutos a 40 minutos, 20 minutos bien, es un tercio en ese sentido. Y en la farmacia sí es en donde se visualiza gran parte también el efecto, porque está informatizado y entonces es más fácil recibir la receta del médico a la farmacia directamente sin llevar ningún papel, y a veces eso agiliza muchísimo. Entonces, la receta digital, entonces este sistema lo está distribuido en un sector de la urgencia, un sector de la internación y un sector de la medicación, que es la medicación. Y lo estamos complejizando, queriendo complejizar un poco más en un sistema de gestión dentro de ese servicio de salud, para que esto pase. Entonces, la infraestructura, el sistema de información en salud, Paraguay contribuye con el 65% en el presupuesto para este proyecto y Taiwán es un 35% dentro de este proyecto. Entonces, de esa forma estamos enviando este sistema llegando a todos los servicios de salud. Estas son algunas fotos de algunos momentos que se está trabajando en distintos hospitales, y aquí quería decirle que la señora ministra de Salud, que está en el centro, al lado justamente también del representante de Taiwán, en la que constantemente enfatiza y lo hace que todos los días estemos dando informaciones como para que se instale en más servicios y la presión a todo el sistema de trabajo a tanto ICDF, a GIS Taiwán y al embajador de Taiwán en Paraguay y constantemente trabajando como para que esto pueda cada vez ser más rápido. Vemos acá algunas fotos en la cual se está realizando, creo que fue una foto del hospital de Coronel Oviedo recientemente inaugurado, un hospital de 300 camas que constantemente está ya todo conectado en este caso. Posteriormente podemos hablar del resultado, entonces, que ya hemos dicho que más de 950 establecimientos de salud con 22.000 usuarios principalmente y que alcanza alrededor del 70% de lo que cubre el Ministerio de Salud. Y más de 1.3 millones de pacientes que están por mes pasando ya por este sistema. Y fíjense, es prácticamente lo que estamos queriendo llegar a lo que es un Big Data con toda esta información. Si tenemos 1.300.000 información por mes en el país, fíjense que en un año con 12 meses vamos a tener 15 millones de informaciones solamente en una de esas de ingresos. Y para poder ver justamente esta recolección de datos, inmediatamente con esta información se han elaborado varios dashboards o varios tableros de monitoreos y inclusive con indicadores específicos en ese sentido. Acá vemos esto, pero apenas se ve, por ejemplo, un tablero de la distribución de camas en terapia intensiva. Teniendo con 6.200.000 personas, nosotros tenemos alrededor de 620 camas en terapia intensiva, de las cuales están divididos en adultos, pediátricos y neonatos. Y un problema es acá, justamente, en la cual difícil de saber en qué hospital tengo terapia intensiva con camas disponibles. Entonces, de esa forma se podríamos nosotros, con el sistema que ha desarrollado a través del sistema de una programación, rápidamente, fíjense la disposición que podemos decir cuántas camas están libres, cuántas están disponibles a pediátricos o algunas camas que recientemente fueron desocupados y está en proceso de limpieza, el proceso de generar la libertad, entonces inmediatamente ya figura en este sistema. También estamos viendo cuánto tiempo está un promedio de internación de los pacientes en terapia intensiva. También queremos visualizar eso para promediar de acuerdo a enfermedades y comparar con epidemiologías, por lo menos regional, de que si un paciente con un diagnóstico de neumonía, cuántos días está ocupando cama. Y además también el otro punto que desde mi punto es muy importante es hacer un poco la economía en salud, calcular los costos rápidamente y conocer cuántos los montos que se utilizan en cada servicio por cada enfermedad. Y para ir terminando, entonces es importante entender el apoyo de la gestión del cambio por parte de los formuladores de las políticas. Creo que se fue al otro lado. La construcción del consenso con niveles centrales, gerentes y hospitales y trabajadores de la salud. Escuchar a los usuarios qué les conviene, qué les gustaría cambiar dentro del sistema y ese momento de hacer como si fuera algo personal del sistema es importante y eso lo estamos teniendo en el GIS actualmente. Y el gobierno debe asignar entonces un presupuesto más operativo para garantizar la sostenibilidad en este sistema, en la cual creemos que es un sistema único actualmente, por lo menos en nuestro país, de desarrollar un sistema de acuerdo a lo que uno necesita y de acuerdo a la especialidad que uno quiere. Tenemos un sistema desarrollado para trauma, que es muy importante, y tenemos un sistema desarrollado para lo que es las urgencias y la terapia intensiva. Con esto nada más quería compartir y decirlo principalmente de que con el trabajo que lo llevamos juntamente, constantemente también con Taiwán y con ICDF y con el ingeniero, Paraguay ha demostrado que es posible avanzar hacia un sistema de salud más inclusivo, eficiente y accesible mediante el uso inteligente de la tecnología, y nada de esto hubiera sido posible sin la incorporación generosa, técnica y humana de Taiwán. Queremos destacar con especial gratitud su rol visionario y solidario que ha sido fundamental para llevar adelante esta transformación. Taiwán no solo ha compartido tecnología, sino también valores, experiencia y compromiso con el bienestar común. Muchas gracias por la oportunidad de compartir nuestra experiencia. Espero que este foro siga siendo una plataforma de diálogo para construir juntos sistemas de salud más inclusivos, resilientes en todo el mundo y con mejor eficiencia. Muchas gracias.
Thank you very much, Vice Minister. And Vice Minister asked a question about how many persons have gone to Paraguay. I'm going to ask you a question. How many persons have gone to Taiwan? How many of our guests? Because I know I have gone to Taiwan and I have been extremely impressed with their IT system. And one of the projects that was mentioned was the strengthening public health emergency response. And that's a project in St. Vincent and Grenadines by ICDF. And we looked at the emergency departments, and all of the emergency rooms are connected. So you are able to see the same information instead of speaking about the ICU beds. You're able to see the occupancy of all of the emergency rooms, and that's something we really would like to see in St. Vincent. I'm sure everybody else would appreciate that. We also noted that the Minister of Health of Taiwan mentioned the willingness to share the knowledge, the experience, the expertise, and that is something we are all benefiting from. We are going to move on now to the first of our other speakers, our panelists. So we have, I've been told that she is okay with me saying just Dr. Marina. I don't want to butcher everybody else's name this evening. So Dr. Marina Michel is the Chief Technical Officer at the Geneva Digital Health Hub at the University of Geneva. And she is going to present this evening, on the, excuse me here, but Doctor's going to come and present. You're going to come up first. Okay, she's going to present on teleconsultations for inclusive healthcare in Nepal and Mali. Yes? Welcome.
Hello everyone. In the beginning, I want to thank the organizer for having us today. It's a pleasure for me to be part of these discussions on smart technology for inclusive healthcare. And I'm here as a representative of the Geneva Digital Health Hub to present you our work on teleconsultation for inclusive healthcare in Nepal and in Mali. Okay, so maybe just to give you a bit of a background, to make the expertise travel instead of the patient, that is the credo of the RAFT network, or the réseau francophone, the réseau de la télémédecine en Afrique francophone. So it's a telemedicine network that we created more than 20 years ago, and the goal was to respond to a need that came to us, that health professionals in rural areas were isolated, they could not have a continuous medical education, and they did not have access to experts to have a second opinion or to help them decide on the diagnosis. So we launched this telemedicine network, first in Mali, then it was extended in the French-speaking Africa, then now we are in Nepal, Bolivia, and in the Kyrgyz Republic. So from all of these different implementation in more than 25 countries now, we have learned from our experience in implementation. For example, we saw that there was an impact on the reference of the patient, which was reduced. There was impact as well on the time saved by the patient by unnecessary travels. There were also an impact on the cost for the patient. But what we observed 2 years ago was really interesting, because in one of our implementation in Nepal, we saw that there were more women than men who came to the teleconsultation. So our hypothesis was that is this because of some kind of cultural aspect of some social barriers, that women cannot travel compared to men, so if there is a care that is accessible near to them, maybe it can ease their process of access to care. But that was just an hypothesis at that time, and we wanted to verify this scientifically. Does really telemedicine increase the access to care for the woman? So we launched this gender study in Nepal and Mali, where the goal was really to build evidence on the effectiveness of telemedicine and understanding this gender-specific aspect of usage of the telemedicine. What was the determinant that drives these gender differences, and to prepare for a scale-up project that I will tell you more about later on. So we launched the study in 2 countries, in Nepal and in Mali. So it's a stepwise approach where we deployed the teleconsultation sequentially in 6 sites in Chhatar Jogbarti municipality in Nepal and 6 sites community health center in the Sikasso region in Mali. So it was a stepwise approach. We made a comparative analysis. So we collected data 12 months before deploying the teleconsultation and then 12 months after deploying the consultation. And we performed a mixed method study where we are right now analyzing the data from the patient, from the record, but we are also investigating through qualitative methods to understand the perception and acceptance of the women of these new services. Where we are in the current status of the project, so we deployed all the teleconsultation in the 12 sites in Nepal and in Mali. We collected the retrospective data. Now we are in the process of collecting the prospective data, and we are monitoring closely the data collection process. So we are in the middle of the study, so we have some preliminary observation, but what we see is that we confirm that there are more teleconsultation from women compared to men. And then the difference between Nepal and Mali, in Nepal it was mostly general medicine, because in the health post where we deployed, they don't have doctors. While in Mali they have doctors, so they were using the teleconsultation to access experts. In terms of qualitative feedback, so most of the patients were really satisfied about the service of teleconsultation, and for them it was the same as in-person visits, so they would use the teleconsultation again. We also faced some challenges, so we had the opportunity to go to Nepal in February this year. So we had the opportunity to discuss with the in-charges, with the health professionals there on site, and they say that yes, the teleconsultation was really useful for them, but there were some challenges. For example, there were no, even though we had the teleconsultation services, there were no medicine or lab services, so they still had to go to the city to do the labs. So if the government is not providing the lab and the medication, the teleconsultation was not really efficient, because they could not save time, they could not save money for that. And then we also had some problem around patient awareness. So we saw that we have to communicate more about the existence of the service through the different channels in the community. And then that the authorities' engagement in the project was really important, specifically in Nepal, because we have 3 layers of authorities, provincial, regional, and national, and we had really to discuss with every one of them to make them involved in the study. So the next step now, we are completing the data collection, we are doing the analysis, and now we are preparing to report all of this in an implementation report. It's a specific scientific article to report implementation that is peer-reviewed in Geneva. And then now we launched, following on this gender study, we launched the scale-up in 100 sites in Mali and 100 sites in Nepal, to follow up on this gender study. So the goal of this project was really to provide the necessary evidence on how digital intervention like teleconsultation can address these gender inequalities. And we really value the sharing of experience, not only the best practices, but also the challenges, because we believe that it's the only way we can advance and implement better. And we have this platform called Implementum and Digital Health Atlas, where we can document your implementation. So we would be really grateful if we have the really nice project in Paraguay there, because we will really have many lessons learned from your implementation. So thank you very much.
Very much, Dr. Marina. I'm sure that you have lots of questions for her later on. So we will have our panel discussions with ask about how this was really done. Our next speaker is Mr. Stephen J.H. Lee. He's the Deputy Secretary General of the Taiwan IeDA, and he will be speaking about promoting the development of smart healthcare in developing countries. Yes, Taiwan's IeDA experience.
Distinguished guests, ladies and gentlemen, good evening. I'm Stephen Lee, the Deputy Secretary General of the Taiwan International Cooperation and Development Fund, the Taiwan IeDA. And in this session, I will be sharing how our public health and medicine project promoting the development of smart healthcare in developing countries. And here is the outline for my presentation tonight. And there will be 4 parts, including the digital health global trend, the smart health in IeDA's project, and also as well as the strategy for smart health. And the last part will be what have we learned from our project in developing countries. Okay, first let's start with a brief history of the global trend toward digital health. As we know, prior to the 2020s, the WHO emphasized the need for e-health and a call for a global digital health strategy. This leads to the endorsement of the global strategy on digital health 2020 to 2025. The strategy promotes health for all and provides an integrated, resource-driven framework to support nations at all stages of digital health development. Then I will talk a little bit about the Taiwan IeDA. Our organization's Taiwan IeDA is Taiwan's official development assistance agency. Sometimes you can call it USAID in Taiwan. Our mission is to improve partner countries' quality of life through 3 levels. The highest level is the government level, then the health institution level, then the community levels. And through Taiwan's these 3 kind of levels, we use the Taiwan's competitive strength, like public health and medicine and ICT as well. Additionally, we will work aligned with our Ministry of Foreign Affairs, a Smart Health initiative under the Diplomatic Allies Perspective Project. So toward the end of the project, we integrate smart health into our public health and medical and medicine project. In ICDF, just I mentioned, for last page, we through 3 levels, government, institution, as well as community levels. The purpose is to further enhance the healthcare accessibility and inclusiveness. Ultimately, we aim to assist our partner countries in achieving universal health coverage. So firstly, smart monitor system visualize data to alert officials to the real-time issue, enable quicker need-based decision-making. Secondly, health management app share patients' information and the personal advice for the healthcare staff in advance, then help them to better understand and accommodate the patient's needs in order to making care more accessible and responsive. Thirdly, data integration and AI-assisted diagnosis expand healthcare service in rural areas in order to reducing the physical barriers to access. So I would like to share some examples we are doing now in our partner countries. First, in Paraguay, just as mentioned by the Vice Minister of Paraguay, our health information system here in Paraguay enable real-time visualization of suspected dengue fever cases. A smart monitoring system cascades the flow of information, enabling the official to reorient resources and bring them closer to the epicenter. Then let's go to the South Pacific. In Fiji, we launched a health management app, which is named Sova Nivula. In Fiji, the meaning of Sova Nivula means the cradle of life. So this app is a digital tool, 100% tailor-made by the town ICDF. The purpose is for the primary health care, and with improving the patient tracking, accessibility, and service delivery. It features automatic follow-up, alerts, outreach, scheduling for remote area, hotspot mapping for resource allocation, and centralized case management. By empowering frontline healthcare staff with timely data and a reminder, so the Sova Nivula ensure no patient is left behind, even in the most remote area. This inclusive approach to healthcare is crucial for building a healthful and more equitable society. Okay, let's go to the Caribbean. In Belize, we introduced a smart health tool which is named VCDR. It is an AI-assisted diagnostic software that helps healthcare professionals to analyze retinal image for signs of DR and immediately outputs recommendation for referral to ophthalmologist. So, as I know, we purchased 4 sets of the VC programs, and last year we put 3 sets in the rural area in Belize, so making every screen service accessible there, especially in the remote areas. Then we go to Africa. In Somaliland, we launched an AI-generated electronic medical record system. In collaboration with the Wharton Business School of the University of Pennsylvania, we developed an AI-generated EMR system for use by the Somaliland Health Information System to improve healthcare service accessibility. The EMR enhances medical completeness, improve medical service experience, and strengthen communication between healthcare providers and the patients. Okay, according to the 4 pillars of the Global Initiative on Digital Health, DIGH, our key lessons including 4 parts. First, customized digital solution. As we all know that, a one-size-fits-all or digital tool cannot meet every country's unique healthcare practice and cultural needs. But second, country-led coordination. Partner country must lead resource allocation to avoid duplications. So with enhanced donor cooperation to maximize the impact. The third, aligned and supportive partnership. Support must align with global standards, providing quality assured tool to guide national digital health transformation. For the last, country ownership. Systems and tools should be co-developed with partners, strengthening local IC capacity and granting full control to partner countries after deployment. That's my presentation for tonight. Thank you for your attention. Thank you.
So Taiwan has been doing quite a lot. I know that's just a sample of all of the initiatives the ICDF is involved in. Our next speaker is Mr. Kalong Mukherji Mukherji. He's the Digital Health Manager of the Terres des Hommes, again. It's an international children's rights organization founded in Switzerland in 1960. And we'll be discussing using the integrated e-diagnosis approach, IeDA, to guide pregnant women and newborn health care.
Good evening, ladies and gentlemen. It's a pleasure and a privilege to be with you today evening. I know it is a little difficult to say evening when a lot of people like us who are born in the more on the eastern side do not see light outside when we say evening. Welcome. We are going to talk about IeDA. I know a lot of people have heard about IeDA in different contexts, but today I'm going to talk more on IeDA specific to IeDA specific to mental health. Before I go into IeDA specific to mental health, just a quick recap. I think while I'm going to specifically speak about a tool, an application, digital application, please look at it as the overall picture, take a step back of what Stephen spoke about and what the minister spoke about, of how we are using the data. While digital tools are many, and this is one of them, and which has shown good success, but it's also to learn from it, and this I guess is coming up everywhere, that how we learn from the data that we collect, how we can improve ourselves, as shown by the minister from Paraguay, that how the timings got improved, and that's where the crux lies. So I'll give a little bit of background of that and go into, but let me also speak about Terres des Hommes, which is a Swiss organization, a child rights organization based in Switzerland, Lausanne. To quickly give you a little bit of idea of where we are and how small or big we are. In 2024, we reached out to something around almost 6 million children and their communities across the globe. And in the health program, we reached around 4.4 million children and healthcare workers through our digital labs as well as outside of it. And we operate in roughly around 30 countries. So in very short, we are not big, but we are not too small. We have a sizable impact on the ground, and which is largely and to a certain extent supported by donors, very much like ICDF, who make our work possible in the grounds that we work. And thank you for that. Integrated e-diagnostic approach does three different things. Number one, it is a medical decision support algorithm, which essentially converts the protocol into a digitized algorithm, which helps the healthcare worker to go through a protocol step by step. So they won't miss anything, they will be able to do it correctly, consistently, irrespective of whether they remember all the steps or not, whether they remember what the track should be. The second one is what everybody talked about before, is the analysis. Now, a lot of times we collect data, but we do not do the analysis, but even at the patient level, because there is a machine learning thing that happens at the back end of the tool, we are able to give that power in the hands of the healthcare worker. And that makes a difference. The healthcare worker doesn't have to think through of what to do. The machine already kind of prompts them to do what is correct to be done. And last but not the least is the strategy of continuous training through coaching. Because we are collecting all the data, we know where the gaps are, where the healthcare worker is getting stuck or where the person is not able to give the correct medicine, so we know where the training is needed. We would be able to tailor our training programs and obviously save costs beyond that. So that's in very short what IeDA is all about. And what we do in maternity specifically is obviously contribute to the reduction of maternal and neonatal mortality across the globe. The reference is clinical protocols which are already established. We do not create a new medical clinical protocol. There are established protocols which are available, which have been evidence-based, which have shown results to save lives. What we only do is convert it from the paper-based to a digitized version so that it helps the healthcare worker to follow to the T. The second is the electronic clinical decision support tool, which I already spoke about. And third is integrated in the health system. Now this is very important. We do not run a parallel health system which tries to replicate what the government is already doing. We work with the government, we work with the health professionals who are already supporting the communities on the ground, wherein they're just getting additional support. So it's a job aid which helps them to do their work better. What it essentially covers is general organization, all administrative files, which is essentially the electronic medical record. Then we have the clinical examination files, so anytime a healthcare worker wants to see what was the patient doing maybe 3 months back, 6 months back, is this a relapse or this is the first time they're having this disease onset, they would be able to look back and check on it. And most importantly, they can also refer to the e-learning model, which gives them the best practices and procedures and advice and guidance that they can quickly kind of piggyback on, which is already available in the app. What it contains, when we essentially started with the prenatal care, which is essentially the ANC, antenatal care package. But we soon understood that the mothers have a lot more requirements, and they have gender-based violence, we have family planning requirement, postnatal care, at-birth care, so all of those. So we started building those blocks around the basic ANC package, and now we are moving on to the digitalization of WHO's labor care guide, which is the final frontier, which most probably will give us a very, very convoluted one. We did some evaluation. This is the most important part, where we wanted to see how we are doing. Are we doing everything right as we hoped to? And this is a slide which my friend Carol, someone sitting out here, who's the Africa regional manager, we debated whether we should share these slides. But it's important to see whether digital has really transformed everything. And it does, in certain extent, and it doesn't. And that's where the learning is important, that we try to pinpoint where we can improve. So if you see out here, it will be a little distant for some of you, the assessment and the preventive treatment are somewhat juxtaposing each other. In the assessment, we have shown very good improvement, while in the preventive treatment, maybe there's a little bit more area to improve. So that's why these digital tools gives us that decision-making evidence that where to focus on. We most probably should work a little bit more on the preventive treatment, so help the healthcare workers to improve their skills on preventive treatment. And that's what these digital health tools can give us. If you see the average duration of ANC clinical encounters, it increases across all parameters, whether it is the ANC number, whether it is the trimester number, or depending on what kind of healthcare workers they are. This is a very important parameter because the more amount of time the mother spends with the healthcare worker can really understand what the mother needs. And this in turn helps the mother also to get enough confidence on the healthcare system. So this was a parameter which showed that once using digital health tools, the consultation are long and totally inconclusive. Then we have evaluation of maternity in Guinea. The first one was in Burkina, this is in Guinea. Here you see two simple graphs which clearly shows there was a higher uptake on contraception when the digital tool was given. Same for births when they used partographs. So usage of partograph improved when the digital tool was given. You see the spikes on the contraception. So these were when there was separate kind of mass media advertisement which happened. And you see when you do the digital app plus the mass media, there's a higher spike after the digital application was brought into thing. So essentially showing when digital app is with another support, it actually kind of multiplies the impact of the public health intervention. We also asked about challenges. So now the slide is not coming, but essentially it shows the perception of all the challenges that the healthcare workers have. So a lot of times they do think that this is going to take a lot more time, this is going to be not easy, the dependency on a hardware which can sometimes break down, all of these can happen. But it's also important to know these challenges and perceptions which we can then work around. And last one, which is the patient experience, which is the most important one, what they feel. And here you see almost 90% of the patients felt that when a digitized tool is used, they have a much better care and improved care, and they loved it. And that's essentially what the bottom line is, that when you are able to give more comprehensive care, the healthcare worker spends time with the mother, they feel a lot more assured and comfortable. Thank you for the time, and really appreciate your patience here. Thank you.
Thank you very much. I'm not sure how you are, but as an administrative physician, this is all very exciting to me. The possibilities and what can happen, and then also the challenges in terms of who is using the technology, if it's the patient or if it's the caregiver, and if there's a difference in that also. Okay, so our final speaker is Mr. Pap. I'm allowed to just say Pap. And he's the founder and president of the Bioba Institute of Health and Development. This is an independent, African-led, non-profit organization. It was created in June 2021, and it's based in Dakar. And he will be speaking on accelerating the last mile delivery through digital health. So let's welcome Pat.
Thank you. Thank you so much. And I should probably also clarify that I'm speaking on behalf of Transform Health Coalition, which is a global coalition that is really trying to help us recenter our focus so that we pay a lot more attention to community health. So the idea would be, as a community, how can we reshape community health care? Because there has been a lot of conversation. It's not a new subject. Alma Ata Declaration is an old one. There was a promise to offer care to everybody, to all population, and we have not succeeded. I think it's fair to say. But the situation we are in today, as we rethink about healthcare in general, I think it's a great opportunity to refocus our attention on community care, especially now that we can dream, because what digital health is going to do is offer us a turning point so that we can go from the traditional healthcare systems to a new one that we're all trying to create. Because you know that the current healthcare system was built with the assumption that we're here to combat diseases. It was not really to promote health. And until we build a system that is ready to welcome healthy people, our work is not done. So that's the challenge we have today. We need to shift from HIV/AIDS, tuberculosis, malaria, although there's a lot of unfinished business, but we need to start thinking about how can we have a system that is strong enough that it's going to be there for the healthy people. And you know what? By focusing and succeeding in community health and last mile delivery, we will create that opportunity. And that's the ingredient that we did not have before, is digital technology. So let me just go through a quick presentation, and then I will leave room for us to engage more into this conversation. So, let's see, where. Okay, I will let you read that because it's about Baobab. What we wanted to do is take a little case study. We picked Senegal here, and it is actually very similar when you look at the region. What is the context under which we are trying to undertake a reform of community health programs? This is a country that is very well known, of course. These are 2023 statistics, which shows that healthcare expenditure in Senegal is about 5%. I'm ashamed to be presenting this because this is not good. This is showing that we could do a lot more, and we need to. We need to push ourselves for a better investment. But that's what it is. It is not the 15% that most of the countries pledged that they wanted to do. It was called the Abuja Declaration. And all of the countries say, we pledge we're going to invest 15% of our national budget in health. Unfortunately, that is not happening. But that's what we're working with. In most of these countries, that's kind of the average. It runs 5%, 6%, maybe 10%. Burkina Faso, I actually learned last week, is spending 13%. That's actually pretty good. Anyway, we then drilled down and we looked at how much money is spending on primary health care. Because that's really what we want to do. We want to talk about community health, we want to talk about digital health, but we really want to talk about strengthening primary health care. And this is the figure. Right now, countries are spending 58%, 58, almost 59%. Not bad. But you have to look at the denominator. It's 5% of the national budget. But a good chunk is being spent already on effort. It could be a little deceptive because that probably, I know in Senegal it goes down to the case de santé, which is the lowest level. But community health in general is not part of the system. So the money we are actually spending on community health program might not be included in this figure. Okay? And these are the types of activities that you will find, which I think is favorable to our goal of revamping community health. Countries are spending, they're doing ongoing training of health workforce regularly. They are deploying qualified staff to underserved areas. There are various strategies, maybe not succeeding completely, but it's happening. They're increasing the budget going to primary health care because I think people are beginning now to hear the message. And they're adopting sustainable financing mechanisms. A lot of countries have now an insurance policy. The government might be subsidizing insurance for the poorest, etc., etc. There are efforts toward looking at that. Electronic medical records, their efforts, it's not national, it's not at scale, but it's happening. And telemedicine. And we've seen this morning with the presentation on Paraguay and the various work that ICDF is doing, we see a lot of good effort. So I think the climate is good for that goal of really revamping this. But it's important though that we spend time and we talk about capacity building, because this is a new field for a lot of people. And it's not just enough to think about the frontline workers or the health workers. When you look at the ecosystem, there are 3 buckets here, and we could probably have more. And these are examples of things that need to be done so that we build good capacity in the field. We need to focus on frontline health workers, of course. One example is clinical decision support system, and we've heard some examples here. And there is more it can be done. If you take the policymakers, same thing. We need to develop this idea about what does that mean to have leadership for digital transformation. It needs to happen, and we need to pay attention and money and resources into this. And you think about the supervisors, for example, and this is just kind of an example. Now, if you want to take it to the community, to the population level, we also need to build capacity so people can react to what we do. These are some key actors and some work. We're not going to have time to talk about that, so I'll just focus on the work of Transform Health. But there's Living Goods, there is Ternism, of course, there's Medic, there's several groups that are focusing on this. But I wanted to just spend some time talking about why we should look at the work that Transform Health is doing, because it is really the work that is trying to coordinate all of this effort by bringing all of the actors together and finally having impact with our policymakers in the field. That's why we need to sort of look at it and look at this work. But they're very, very good players. These are the typical challenges we see when we try to expand at community level: infrastructure gap, fragmentation, interoperability issues, hurdles from pilot. We're piloting. But we need to take these things to scale so that we have national level programs. And then we can really have sort of a policy alignment for financing and real local ownership. I think that's where the presentation is going to stop, and I think my time is just telling me I have a few seconds left. So I wanted to thank the organizers for putting together this. This is not only timely, but it's important that we start focusing at that level, that we correct the mistake we made by not giving attention to the foundation of healthcare system, which is the community part. So I invite you to continue the reflection, but also to share what we're doing. And a good forum would be the Transform Health Forum, but there are others. So thank you for giving us a few minutes to share this experience. Thank you.
Okay. Thank you very much, Pap. And now I'm going to invite all of the presenters to come up onto the platform to have a seat so that we could have our panel discussion. Okay, so just a reminder, you can use the Slido. You have to scan the QR code so that you can get the questions going. Okay? Just wanted to make a little comment also. Paraguay had a population of, what is it? 6 million. Want to guess what our population in St. Vincent is? Not everybody from the Eastern Caribbean, they know. We are a big boy, relatively speaking. We are 110,000 persons in St. Vincent and the Grenadines, 32 islands and keys. And you might think, okay, well, we won't have problems with access. But we do, we can still have challenges because access is not just a distance, it's just not a physical distance. It talks about access to services more than the distance. Is it appropriate for what you have? So this discussion is extremely relevant for us. We also want to welcome some delegations from St. Lucia. They have they're bigger than us. I think they're 130, 183, you see, very big. Population 183,000. We have St. Kitts Nevis, have a population of 51,000. And then we have Belize. Belize has plenty more persons. Belize's minister, 430,000. So we welcome. So we have a range, but again, access and universal health coverage. So, questions. I'm going to start with the first question. So I would like to know more about how the government of Paraguay use policy tools to reach such a result. How could you please provide some examples? How did you manage to get where you got to? What were the policy decisions needed to ensure that you had such good results?
No.
Could you repeat the question? I'm sorry, I had a technical glitch.
Sorry, the question was, I would like to know more about how the government of Paraguay used policy tools to reach such results. Would you please provide some examples?
Bueno, gracias. Con este gobierno que ha iniciado el 15 de agosto del 2023, uno de los pilares del plan de gobierno es justamente hacer la transformación digital en este caso en el Ministerio de Salud Pública y Bienestar Social. Y en eso ya ha iniciado el sistema GIS a nivel Paraguay, pero este gobierno ha impulsado en implementar en el 100% de los servicios de salud. Entonces, siendo una política de gobierno para una política de salud pública, entonces ha apostado en el proyecto GIS y ha hecho la alianza, o sea, ha hecho más fuerte la alianza con Taiwán como para implementar esto. Y con esta idea se ha iniciado y se ha hecho la inversión en infraestructura tecnológica, infraestructura de recursos humanos y por supuesto la infraestructura de una base de datos con distintos tipos de ayuda interinstitucional. Significa que el Ministerio de MITIC, que es de Información y Tecnología, es el órgano que coordina totalmente toda la información y base de datos en el Ministerio, en el Paraguay, y a partir de ahí el Ministerio de Salud, a través de la Dirección General de Tecnología e Información, también trabaja exclusivamente con, en este caso, GIS, Taiwán, como para la implementación. Y de eso se planifica y eso está en avance total actualmente.
Thank you, Vice Minister. I have another question along that way in terms of resources. And the one I'm going to pick was in resource limited areas. where people lack digital literacy, could smart healthcare technologies actually worsen existing inequalities in healthcare access? So I'm not sure which of who would want to jump on that.
Bueno, en esos lugares...
Yes, it's good. I think I'll get started and Pat can kind of chime in. So this is a conundrum which all of us face. The places we work are always resource constrained. We cannot expect that we move into a community where everybody will have a smartphone. I come from a country which has a very good mobile phone coverage, which is India. But when you talk about smartphone coverage, that changes a lot. It comes down to less than 30% as the smartphone is concerned. So just because somebody has a phone doesn't mean they can use smart technology. So if we are going to reach out to the rural areas, to the distant places, it becomes a challenge. And it does have inequalities. But does it mean that we do not go into those areas? We stop going in out there. We have had these situations in humanitarian settings where we try to bring in digital solutions in refugee camps, where obviously there is almost like no smartphones. So what we have to do is we have to find a way to overcome those resource challenges. Can we build a kiosk where people can come in and get information? And individually people does not need to log in individual records and just get health information directly by providing their inputs. So what we want to go into is how do we cover or how do we overcome those barriers rather than stop just because there are barriers. There would be barriers, and obviously smartphone is just one of them. There are so many others. Digital literacy, just because somebody has a phone doesn't mean the person can read what it is on the phone. So how do we convert that? Can we convert language? Can we move to voice, thereby eliminating that barrier of reading? So we kind of, the digital health does offer so many options to overcome those resource challenges, and that's where I guess people like us have to focus on. That yes, there will be barriers, but how can we overcome those barriers is the most important part. Would you like to chime in?
Sure, I couldn't agree more. I think we are also underestimating the power of how creative people can be. So I think we have a lot more work to do, but we need to find these solutions that are going to counter some of the things. More a solution for working offline, and then you can download when you finally have access, things like that. But we should not stop, and I think we should continue to provide the tools, and we also need to increase the investment with technologies that are going to reach more people. I know in the case of Senegal, for example, the fiber optic is going to take a long time to arrive everywhere in the country, but as soon as satellite system and exist, we should use those. So I think it's a long haul, but it's also very impressive to see the progress that has made in the last decade. It is incredible how technology has revolutionized other sectors other than health. For example, Kenya was a big hub with the Ushahidi movement that really created this uprising and this engagement of society into election and election results. So we're seeing the impact it's making in those fields. As a matter of fact, if we're not careful, the health field is falling behind a little bit. I think because of all the problems we are creating, it's overcrowded, there's lack of coordination, there are too many solutions, and so forth. But lots of work to do, but that should not be an excuse. I totally agree with that suggestion.
Thank you very much. I'm being told I can only take one question, even though I went very quickly, I think, but this is such an important topic. I hope that we will be able to continue the discussions otherwise. I'm just going to take my prerogative and just come back to the finding that more women use, Dr. May, that more women use the telemedicine. But we know that women generally seek healthcare more than men. So I was just wondering about that and about the willingness to use this thing, the technology in general populations. So if the persons have the technology, are they really that more willing? And is it really that the women are using it more? Or it's just a continuation of females always seeking healthcare more than men?
Yeah. So since now we are really in the middle of analyzing all the data, we can already see that we can verify through the data that we have collected what we observed before. And our hypothesis is that it may be linked to cultural barriers, because especially in Nepal, the men they are going to work or going to work in other countries, so the women have to stay with the children. And we see that there are a lot of teleconsultation of children as well, where women came with the children. So I think there is a cultural context there, where of course women go more often to the doctor than the men, but we see that it really facilitates the access to care because they don't have to travel anymore. They can have access to the care in close proximity, and that's the real advantage that they have. They can take care of the household, but they can also have access to care for the services that we provide.
Okay, thank you very much. We're going to have to wrap it up. I really want to thank the panelists. Very interesting discussion. I'm sure the audience, you think it was really good. The questions online, I'm going to put, I see there a little commitment here that there will be questions on Slido that we will ask the panelists to still answer some of those questions there. So, you okay?
Okay.
Yeah, okay. And I'm going to close it out now. Thanks everybody for your patience this evening and for attending and your participation. Be good.
So, I know I'm the only thing standing between you and dinner, so I'm going to be quick. Our keynote speaker, Vice Minister of Paraguay, Honorable José Ortellado, Minister of Belize, Honorable Kevin Bernard, and Minister of St. Vincent and Grenadines, Honorable Clair Prince, and also Vice Minister of St. Kitts and Nevis, Honorable Curtis Martin, and ladies and gentlemen, distinguished guests, good evening. Thank you for joining us. So it's really my honor to standing before you to conclude this forum on empowering through inclusive healthcare, leveraging smart technologies for accessibility. So as digital tools and smart technologies become more common, they are reshaping how we tackle public health challenges. These innovations offer new ways to close healthcare gaps, especially in places where medical resources are limited. Tonight, we've heard many valuable ideas about how smart technologies can be applied in underdeveloped areas and how they can improve healthcare systems. We've learned from diverse viewpoints and explored creative ways to make healthcare more accessible for everyone. So I'd like to echo what our Vice Minister José Ortellado just said and all of our other speakers have already shared. Digital health is transforming healthcare in many ways. Tools like electronic medical records and AI are changing the way we deliver medical services, conduct researches, and support public health. At the same time, we must consider data privacy, equitable access, and the ethical challenges these technologies may bring. Looking ahead, now is the time to accelerate our efforts. In today's interconnected world, we can detect outbreaks earlier, We can share information faster and collaborate in real time, all of which help us to save more lives. As Taiwan's official foreign aid agency, the Taiwan ICDF is working alongside the Taiwanese government under the Smart Healthcare Flagship Program under the Diplomatic Allies Prosperity Plan. We are supporting partner countries in building resilient health information systems, such as those in Paraguay, and developing AI-powered tools, such as in Fiji and in Belize. But we know that technology alone isn't enough. Real progress depends on thriving health and innovation ecosystem. That's why we emphasize cross-sector partnerships, capacity building, local leadership, local ownership, and community engagement. Only when policymakers, healthcare providers, researchers, tech experts, and local communities all work together can we truly transform healthcare for the better. Through all these efforts, the Taiwan ICDF hopes to strengthen healthcare from national institutions to grassroots communities. I encourage other international aid agencies and organizations to join us and invest more in international development and humanitarian work. Today, we can build a healthier and better connected world, where fast action and strong health systems become a reality. On behalf of the Taiwan ICDF, I sincerely thank the Terra Home, the TDH Foundation, the National Health Research Institute, and the Foundation of Medical Professionals Alliance for coordinating this very meaningful event. I'm also very glad to see representatives from government, from academia, from industry, and from NGOs here tonight, with speakers joining us from around the world, including St. Vincent and Grenadines, and also Paraguay, and also Madagascar, Senegal, and India, Switzerland, and Taiwan. So thank you to our moderator for doing such an amazing job, and for all of our panelists for your valuable insights. And finally, thank you everyone because you made this forum a success. Thank you. The only thing between you and dinner is now removed. Thank you so much.